Thank you for the kind introduction. I really want to thank Professor Marcelin for inviting me. This is my first meeting, actually, and it's an amazing achievement. And to know that it's been going on for more than a decade, I'm sorry I've missed it. But really so impressed with the speakers to date, and I'm really very, very honored to be part of it. For most of my career, I've spent a large part of my time thinking about managing hepatitis C and hepatitis B in the context of liver transplantation. And that's sort of what inspired me to talk about the issue of how the etiologies of cirrhosis are shifting in a major way in the last 5 years, and with it, the new challenges that we are now anticipating. So if we look at liver transplantation both in the United States and in Europe in 2019 and beyond, we really have sort of a new big three. Hepatitis C still ranks among those important etiologies and common etiologies for transplantation, but we've seen really a dramatic decline in HCV in the last 5 years in the setting of DAA therapy. And in the United States, over a period of about 5 years, we've seen the proportion of patients listed for liver transplantation of hep C drop from 30% to 18%. These are ones without liver cancer. And simultaneously, we've seen a really marked rise in alcoholic liver disease as an etiology, and also NASH. And those same patterns are largely seen in Europe, although Europe has always had alcoholic liver disease as the #1 etiology, and it remains steady. And you can see that NASH is maybe lagging a little bit behind the United States, but it's definitely on the rise as well. So what I'd like to speak about today is really those big three: hepatitis C, alcohol, and NASH. And first of all, we can rest upon sort of the great achievements of DAAs in this context. We know that part of the reason why we have fewer patients being listed is because SVR is associated with less need for liver transplant. We see dramatic decreases in rates for cirrhosis, and we now know that effective treatment also lowers the risk for cancer by about 70%. And even individuals who are decompensated can have reversal of those symptoms. We see delisting in about 20% of the patients that are currently on the list. So all of this has contributed to that marked decline in HCV that we've seen in a really very short period of time. And while post-transplant HCV recurrence used to be a major challenge and the most common reason for graft loss post-transplant, that is now a thing of the past. We can prevent hepatitis C infection from being a major pathogen post-transplant. We can take patients who've had disease, treat them, and we see reversal of their fibrosis. And the issue of retransplantation has essentially disappeared. And we have so much confidence now with respect to our management of HCV in the transplant setting that we are now taking HCV-infected organs and giving those to individuals without HCV and treating those individuals effectively. So it's really a changed landscape in terms of how we're managing hepatitis C in the transplant setting. It's led to changes in the list, and I think it parallels what we saw with hepatitis B and its impact of therapies a decade ago. As you are effectively preventing cirrhosis and decompensation, really what you're left with is those individuals who have liver cancer. This is a very nice study from Spain in which they looked at how their transplant waiting list composition has changed over the time that the DAAs have been available. And you can see there's been a marked decrease in the proportion listed for decompensation and really an increasing proportion that are listed for liver cancer. And we're seeing that in our center as well. We're largely now, we're doing transplantation for individuals who either are referred late in the course of their hepatitis C or whose primary indication is HCC. Now I'm going to shift to alcohol, which is now #1, both in the United States and Europe. You can see on the left, the blue line represents alcohol, and there's been a marked increase basically since about 2011. And as I mentioned before, in Europe, alcohol has always been a very prominent and common etiology in terms of indication for transplant. No significant change in Europe over the past decade, represents about 25% of the transplants, whereas in the United States, we've seen about a 50% increase over about a 5-year period. And the question we have to ask is sort of why did alcohol suddenly become such a prominent indication for liver transplantation in the United States? And initially it was thought, well, it's just because hepatitis C is no longer a big player, and sort of filling the void is all those individuals who have other indications, including alcohol. There's also recognition that we're now transplanting more patients with severe acute alcoholic hepatitis. That's shown in the graph on the left. And it was the landmark study from Matt Turan and colleagues that was published that really sort of set the stage for people to think about using transplantation as a therapy for select patients that have severe alcoholic hepatitis. And you can see that a very small percentage, but is rising in the United States. But that doesn't account for the main change in the US. And I think really what it comes down to is that there's generally a shift in attitudes about transplantation for alcoholic liver disease. Many programs used a 6-month rule of abstinence in the past, and I think really that has shifted. And I think it's that major change that has resulted in alcohol now finding itself in a greater proportion of the transplants in the United States. The outcome of patients with alcoholic liver disease is excellent. This is data from the European Liver Transplant Registry from 1988 to 2005, a large number of patients, 10-year survival, and you can see that alcohol is comparable to the etiologies of viruses and cryptogenic liver disease. And while this is an older cohort, if you look at a more updated registry data and outcome data from the European Liver Transplant Registry, you can see that, again, alcohol does very well. These are 3-year data, but from a more recent cohort, alcohol does as well or better than other etiologies. But there's clearly some challenges as we think about doing transplantation in this population, especially in the United States, as we're seeing this very rapid rise in alcohol as an indication. And I want to focus on 3. Infections, which are really more an issue, I think, related to transplantation of patients with severe alcoholic hepatitis. But also, probably more importantly, I think, is the issue of malignancy, underappreciated, I think, and really is a very important competing risk for post-transplant mortality. And then, of course, the sort of always major issue of concern for alcohol relapse. So it's well recognized that alcoholic liver disease, this is a very nice review article that was published last year in JHEP, really focusing on sort of the immune dysfunction seen in alcoholic liver disease patients, both related to the effects of alcohol use per se, contributing to immune deficiencies, but then as patients progress to cirrhosis and then develop acute on chronic liver failure, or in the setting of a severe alcoholic hepatitis, you have a superimposed systemic inflammation that really sets the stage for these patients to be at significant risk for bacterial and other opportunistic infections. And there are some data. I would say the best data is really, again, in the setting of severe alcoholic hepatitis. This is data from the Accelerate AH cohort. This is a multi-center cohort in the US that's studying severe alcoholic hepatitis and transplantation. And this is just looking at, among the 147 patients that have been transplanted for this indication, they've had 18 deaths. You can see of the early deaths, the 9 who died within 90 days of transplant, 5 of those related to sepsis, and 8 of 9 of those patients received steroids pre-transplant, suggesting that it's both the setting of severe acute alcoholic hepatitis, maybe recent alcohol use, as well as potentially effects of prednisone contributing to this early mortality. So we might need to be thoughtful about this as an ongoing issue as we continue to expand the indication for liver transplantation in this direction. Alcoholic liver disease is also one in which post-transplant they have very significant risk for malignancy, and specifically malignancies that are tobacco-associated or traditionally considered to be tobacco-associated. So shown here are the standardized incident ratio for females and males. These are all post-transplant patients with their primary indication for transplant being alcoholic liver disease. And you can see there's substantially higher rates of lip, mouth, pharynx, esophageal, larynx, and lung cancer in these individuals. So much so that really this becomes the dominant cause for mortality in these patients beyond 5 years post-transplant. And really what this highlights for us is both the importance of stressing the importance of abstinence from cigarette and tobacco use, but also probably a need for us to introduce surveillance protocols for these patients, given this very high risk, and the need for us to identify these patients earlier to try to prevent this post-transplant mortality risk. And then, of course, alcohol use post-transplant. This is, of course, the sort of major concern in this patient population. And the proportion that return to harmful drinking, it's variously defined, is typically reported around 20% at the sort of 1 to 5 year mark. This is one study from 3 French centers, 712 patients followed for 9 years. And what you can see is of those that return to heavy alcohol use, which they defined as 2 or more drinks per day for women and 3 or more for men on an average basis for more than 6 months. 18% of patients met that definition. The median time from liver transplant to relapse of that heavy alcohol use was 1.1 years. And really what this study highlighted was that not everybody who returns to drinking develops histological evidence of liver disease or progressive liver disease. In this case, 1/3 developed actually recurrent cirrhosis over the period of follow-up, and you can see that those that develop cirrhosis have a high rate of graft failure, with 70% of those individuals who are dying with a graft that fails, so really dying of recurrent alcoholic liver disease. And so this is shown in the figure here that those that return to drinking, and especially those that return to drinking and have evidence of histological disease, are at significant risk of dying of that complication. So obviously, this is something we want to prevent, something that we would want to avoid occurring. But I'll emphasize the proportion and emphasize that we really need to understand who these individuals are, since obviously not every patient returns to harmful drinking. And there are so many studies that have tried to look at what pre-transplant factors can be predictive of harmful alcohol use post-transplant. And there are some common themes that are emerging. For example, individuals who are younger are at higher risk for return to harmful drinking. Those that are not partnered, not employed, lack social support, lack insight. Those are very common themes as we look at the predictors that are being identified in studies. And the problem with all of these is that while in individual studies they may be associated with return to harmful drinking, that really not any single factor or combination of factors have been shown to accurately predict who's going to return to heavy or harmful drinking post-transplant. So we really lack the tools to actually be able to upfront identify who those individuals are, either to select better for transplant, but probably more important, to put in place interventions that would help individuals to minimize their risk for return to harmful drinking. I think this is an important study, and one in which we want to see more data of this kind. This is a study in the US in which they interviewed patients post-transplant. They identified individuals who had returned to, again, harmful patterns of drinking. Here they used the timeline follow-back, which is a way to quantify the amount and the frequency of drinking, and they interviewed the liver transplant recipients as well as family members, and they also relied upon blood alcohol done at each clinic visit. In this study, they identified 5 different trajectories to alcohol use post-transplant. And importantly, what they identified is that there are sort of 2 groups that return to alcohol use early. You'll note the green line shows somebody that has an early onset of alcohol use and rapid progression to moderate use. And the yellow line shows the one that has rapid progression to heavy use. And why are those early return to alcohol patients important? Well, what they showed is that it's that group of individuals that seem to be associated with the worst outcome in terms of the graft and patient survival. So you can see in the early onset group, they're more likely to have steatohepatitis on their biopsies, more likely to have rejection potentially related to adherence issues, and certainly had higher rates of graft failure and more likely to have both death and graft failure from alcohol-related causes. So potentially this is one important clue for us in terms of the group that might be at risk, and would be a group in which we'd want to have a very specific targeted intervention that's in place both pre-transplant and continued post-transplant to try to minimize the harm. And while I don't have the answers, I think this is actually an area in which we need many, many more studies done. I think it's very typical in transplant programs that we spend a lot of time evaluating them pre-transplant, get them to transplant, and then post-transplant we sort of let them down, or at least we don't have a formal program in place to help them to remain abstinent or to minimize the risk for harmful drinking. So as we think about strategies to try to improve our outcomes and to ensure that patients who get transplanted for this indication do well, I think we both have to think about how can we do better selection pre-transplant. I think it's really well established in the literature that if they have anxiety or depression, treating those complications, those comorbidities is important to helping them in terms of remaining abstinent. I think engaging in programs that are embedded in the liver transplant program has been shown to be particularly helpful, and I think transplant programs have to think about how they can be better supportive of their patients with alcohol use disorder going through transplant. I think medications that are used to help with adherence in the non-transplant setting need to be tested and evaluated in the post-transplant setting as well. and also, of course, the role of monitoring to help us in identifying patients that are at risk and trying to intervene early. So I'm going to shift finally to NASH, which is the one which I think has received the most press over the last few years, mostly because it's not the most common, but it's the most rapidly rising indication for liver transplantation in the United States. And this is data of many that have shown that basically since we started making the diagnosis of NASH in the transplant list, you can see that the proportion has rapidly risen. And now NASH is the second most common indication for liver transplant in the United States. It's actually surpassed hepatitis C as an indication. And what's I think has been highlighted very nice by the prior speakers around HCC is that HCC is a very important complication that leads to transplantation. While HCC among our waitlisted patients with hepatitis C is declining, again showing us the benefits of DAA therapy. As was highlighted by a previous speaker, NASH is actually the etiology for which there's been the most dramatic rise in HCC in terms of the proportion needing a transplant or being listed for transplant. For alcohol, there's been no change, and for hepatitis B also there's been a decline. So the concern is that we are going to see more and more cancer in our NASH patients in particular. Survival in this group also currently looks very good. So when we get these patients to transplant, we are, of course, selective, I think, in terms of how we're evaluating these patients, given their comorbidities related to cardiovascular disease. But when we transplant them, they do well. And this is looking at patient and graft survival at 3 years and comparing it to other etiologies. And you can see that NASH does as well as viral etiologies, autoimmune disease, et cetera. So what are our challenges in thinking about the NAFLD or the NASH population? And I think it comes down to really the metabolic drivers of both their liver disease, but also their comorbidities that are going to place them at risk for complications post-transplant. It's well recognized in the non-transplant setting that cardiovascular disease is the #1 cause for mortality, and you can envision that post-transplant that's likely to continue. And then I want to speak just very briefly about the risk of NAFLD recurrence. So just to sort of make the point that you're all very aware of is that, unfortunately, every drug that we use post-transplant for immunosuppression has metabolic complications. And so when we take a patient who already has a metabolic risk profile and then add to that the immunosuppressive therapies, we pretty much guarantee that we're going to make those worse, whether it's their diabetes, their dyslipidemia, or their hypertension. And so this is, I think, why this particular group of patients is particularly complex in terms of managing post-transplant. We have a very high-risk group for developing worsening complications. And we'll start with weight gain. It's recognized that about most patients who go through transplantation gain weight. It's very typical. Regardless of whether you have NASH as your cause for transplantation or not. And this is just a small study, but I think an informative one, to say that not surprisingly, NASH patients, they gain weight earlier and they gain weight to a greater degree than non-NASH patients. And if you look at 3 years after transplant, 60% of the transplant patients are into the obese or morbidly obese category. And that's much greater than in the non-NASH group. So we have weight gain. I mean, a lot of us have criteria that they have to be a certain weight to get a transplant, but then after transplant, a lot of these individuals gain weight and put themselves into a much higher risk group. So this has brought up the idea of whether we should be considering bariatric surgery in this transplant setting, and the experience here is relatively small, but I raise it because I think it's maybe an important thing to consider. Certainly sleeve gastrectomy is regarded as a procedure of choice here, primarily because it ensures adequate absorption of immunosuppressive drugs, and it's easy access to the biliary tree if patients develop post-transplant biliary complications. There are some very limited experience. At UCSF, we've done 34 patients pre-transplant as a way to make these individuals eligible for transplantation. Obviously, these are patients with lowish MEL score and who don't have very severe portal hypertensive complications, so a pretty select group of patients. But it is a strategy that has allowed individuals to be eligible for transplant, and we've had no deaths or decompensations by carefully selecting those patients. The Mayo Clinic has published, and I think is sort of the leader in terms of doing bariatric surgery concurrent with the transplant. Again, they do sleeve gastrectomy. It's not without some challenges. You definitely need the expertise to do it, but I'm going to share with you some of their results in terms of post-transplant outcomes. And so far, they've had no deaths or complications of great severity. And then There's now an emerging literature regarding doing post-transplant bariatric surgery. Pretty limited numbers of patients that have been reported, a few cases per site. It's complex, I think, the surgery, probably related to adhesions and other things. In the one small report that just came out, there was 2 complications, and in one of them it led to death. So it's not to say that this is the answer, but I do think we're going to see more around this idea of bariatric surgery and how do we minimize our chance for those post-transplant patients to develop and have worsening of their metabolic complications. And just to say that if you have bariatric surgery done, this is the Mayo experience, and they just published this recently. It's pretty impressive in terms of the benefits to the patients. So you can see here in the individuals who had liver transplant plus sleeve gastrectomy, in the graph on the left shows the group in red is the group that had the sleeve, and the blue is the group that had liver transplant without the sleeve that was of comparable weight pre-transplant. And you can see that the group that got transplant without the sleeve regained their weight and actually whereas the sleeve gastrectomy group was able to sustain weight loss. But probably more important is really to see the potential impact of that surgery on metabolic complications post-transplant. You can see about a 50% reduction in the likelihood of having metabolic complications post-transplant in the group that had sleeve. And we should care because there's already data that shows that in our NASH patients compared to non-NASH patients after transplant that we see more cardiovascular deaths. This is a meta-analysis looking at cardiovascular events post-transplant, and you can see that this is a group in which we see an enhanced risk. And what do we see it? We see it not only in the long term, but even in the short term. And these are in carefully selected patients for transplantation. But within the first year, there's a higher rate, about a 4-fold higher rate of a cardiovascular event within the first year after transplant, including higher rates of cardiovascular arrest and cardiovascular mortality. And then finally, there's often a more higher rate of these individuals having chronic kidney disease coming into transplant. There's higher rates of simultaneous liver kidney transplants in NASH patients than non-NASH patients. And even post-transplant, we're seeing that renal disease is of higher frequency. And again, another concern for us, for our patients. And it just highlights, again, in managing our immunosuppression, being thoughtful that this is a group that's at higher risk for a decline in their eGFR post-transplant or of having a loss of kidney grafts even after SLK in that NASH population. And then the final issue is recurrence of NAFLD. So I'm sort of reminded when I started doing work in hepatitis C post-transplant, we weren't that worried about hep C either, and then we soon came to learn that hepatitis C was our biggest problem post-transplant. I'm not sure that's going to be the same for NAFLD, but this is also a condition in which it's going to recur post-transplant. And as we get better at managing the other metabolic comorbidities, this is something we have to be very aware of. There's relatively modest data about this, but this is a single US study in which these were non-protocolized liver biopsies, but they had a lot of biopsies and TE data. And the bottom line is that the majority of patients do develop recurrent NAFLD. And NASH is obviously the bigger concern. In this study that had a follow-up of up to 4 years, 40% of the patients had NASH recurrent on their biopsies. And probably the more concerning thing is that a significant proportion of those individuals had advanced fibrosis. 25% had significant fibrosis, F2 or higher. And the interesting thing is that in this study, in which the biopsies were not protocolized and often for call, was that there's a poor correlation between the NASH diagnosis and fibrosis severity, and it could not be predicted by ALT levels. And so I'm not sure every program is doing protocolized liver biopsies in our NAFLD patients post-transplant, but this certainly would suggest that we should be on the lookout for this disease and that protocolized biopsies may be necessary. If you take all the literature together, the sort of emerging picture related to the recurrence issue for NASH is that steatosis is essentially very frequent, develops rapidly. 60% of NASH patients have it at 1 year. NASH, I think, a little less accurate in terms of the numbers. Up to 60% will have NASH at 3 to 5 years. Advanced fibrosis, maybe 5 to 10% at 5 to 10 years. So far, there's really no association with having this histological outcome and higher rates of graft loss, but it may be that we're not seeing long enough follow-up in these individuals, but it also may be that, again, the cardiovascular morbidities and other things may be bigger problems in these patients post-transplant. How to optimize the outcomes here, I think it's all about patient selection, but most importantly, it's about managing immunosuppression. More importantly than anything, it's going to be on minimizing the contribution of immunosuppression to their metabolic comorbidities, and really having a multidisciplinary approach to managing these patients post-transplant. That means really coordinating their care with their primary care or other specialists to ensure that we're aggressively managing hyperglycemia, hypertension, and dyslipidemia. So just to summarize, it's a real changed landscape. In 5 years, we've gone to something there where Hep C was really number one to being something quite different. Now we still have Hep C, but it's really a very manageable condition for us, and really it's one of managing HCC. Alcoholic liver disease on the rise. It's going to be, I think, one which we'll see even more as attitudes regarding sobriety requirements change. Remember the importance of infections, malignancy, and the ongoing need for us to assess and manage alcohol use disorder post-transplant. And then NASH, we're not going to, it's only going to get bigger, and that's no pun intended, as time goes on, both from the point of view of cirrhosis and as an indication for HCC. This is going to be a challenge because we're going to have to partner with a wide array of primary care and other specialists to ensure good outcomes for these patients. And remember that recurrent NASH, although it doesn't seem to be a big problem now, I think we need better natural history data, and I think it's going to still sort of potentially be a big problem for us in the future. And with that, I'll thank you.
Thank you, Nara.